Hello, everyone. Welcome. We have everybody on mute just because there's so many people, but we really want to welcome you. We have the chat open, so you're more than, I would love to know where everyone is from. Let us know. We know we have people here from coast to coast. I've got my team in the Bay Area, New York, and all around. Hi, we got New York and more New Yorks in the house. No, but welcome, and we're so excited. We're gonna wait a couple minutes, probably about 5. We'll start about 5 after, so about 3 minutes. We'll get started. But we're so, Hannah, I am from San Diego too, so welcome to you. 619 in the house, yes. But I'm so excited for everyone to be here today, and I have a wonderful group. We have amazing patients that have babies in their bellies. We have our physician, our chief medical officer is here. My amazing Emmy, who is right there with the mask. She is about to leave on maternity leave, so we're very excited for her to be here with us too. And her baby is from IVF as well. So we have a lot of amazing people and energy and excitement to be with you here today. So thank you for joining us, and we'll just take a couple more minutes. Hi, Stephanie from LA, welcome. Dr. Brower is in Los Angeles, and I lived in LA for almost 20 years, so I believe you. I miss LA a lot, so I go to visit Santa Monica. It's 2 birds with 1 stone. Selfishly, I get to be back in my city, and I get to be with my amazing Kindbody family in Los Angeles. So welcome, Kylie. Thank you, everyone. Just a couple more minutes. Oh, hi, Judith. We have our therapist, Judith, here from New York. Oh, Whitney, you're back on. We got you back on, girlfriend. I was teasing her that she had pregnancy brain, so she had to do some downloading on there. And we have Anthony M. Brown, who is here from New York. He is a parent through surrogacy. We've got a lot. Let me unmute for Whitney. Here we go. Get you.
Wow. I'm unmuted, folks.
Yeah.
I mean, talk about panic. It's like, here's the thing. I have pregnancy brain, but it's also like, throw in the mix, like all these technological updates. How are they going to do me like that? Like, don't they know that I'm pregnant? I can't take this. I've got it.
We got it. Okay, we'll just wait 1 more minute and we'll get started. But again, feel free, and then just so you know, we're gonna talk a little bit about, we're gonna have Dr. Westphal, who's our chief medical officer. We have Dr. Brower, who is the baby maker of our wonderful Whitney here. And we've got, we're gonna talk about a lot of different things. We'll talk about the medical process, and then we're gonna talk and hear some real people, real patient experience and real journeys of people who have gone through the process. And then we also have Lori Smith, who's here from Donor Concierge. She's gonna talk about resources and next steps. And then because you're attending tonight, we have some wonderful discounts from Seattle Sperm Bank, from us. We have some wonderful things to share. And then we'll also answer questions. So feel free, we're gonna talk about a lot of different things, but feel free to put things in the chat. And then at the end, we'll answer them, or we'll answer them as we go along. But in earnest, we are so happy to have you here, and we'll get going in just a moment. I'm going to go back over here. I love how many wonderful people we have. So I'm going to start from the top. I have got myself, I'm Tracy Reynolds. I work here for Kindbody and a huge advocate for inclusive fertility care. We have our amazing patient, Whitney Mixter, who is my co-hostess with the mostest, who's going to help me interview and talk and share her experience. Whitney, you want to say hello?
I would love to say hello. Sorry, I was waiting for you. Hello, everybody. It's so exciting to see so many of you in here. Some people I know, some people I don't know. Feel free to ask questions galore. And, I'm so honored to be able to share, be able to facilitate between, members of my community and this amazing place, Kindbody, which I've come to love so much. They're like family.
And then also we have Lori Smith, who's here from Donor Concierge. She's up in the Bay Area. We say hi, Michelle.
Hi everybody. Nice to see you all.
We also have Anthony M. Brown, who's with Circle Surrogacy Agency. Anthony, can you see, did we get you? I want to make sure you're not on mute. I apologize if you're muted. Well, there you are. Let me get you off mute, Anthony. Okay, there you go.
Hey, how's everybody? For having me.
You're so welcome. We're so happy to have you here. We have Jess and Adriana, who are from New York, who are new. They're our Kindbody poster wonderful couple. I was just telling them that their wedding picture makes me happy every time I see it. And they are newly pregnant, and so we want to say hello to them.
Hey guys.
Hey everybody.
Thank
So
you.
excited to be here.
And Whitney I introduced, and then we have our two amazing physicians. I have Dr. Lynn Westphal, who is our Chief Medical Officer.
Hi.
Yeah.
In Northern California.
Yes. And then I have Dr. Meredith Brower, who's going to take it away from me and let us talk a little bit about herself, about Kindbody, and get us started.
Thanks, Tracy. Let me see if I can figure out how to share my screen here. So here we go. Let's see.
And just for everyone, for the sake of everyone, we're going to talk about the whole process. But in this conversation, and also this really speaks true to Kindbody, in our very best efforts, we always want to be inclusive, and we are always open to learning, and we're all very much learning. We just had an event yesterday with Tristan Reese, who is a trans advocate, and we're doing our best. So for the sake of this conversation, we're really going to break it down into the basics that Meredith will go into, but we're talking about, when we say female, it's about female assigned at birth and male assigned at birth, just as far as having the conversation and explaining what the process is to family building. And again, it's not in any intention to be offensive, but and we're again always learning, but we want to, in this conversation, be able to explain it in the best way that we can. So sorry, go ahead, Dr. Brower.
Thank you, Tracy, and thank you everyone for joining us tonight, all our speakers as well as our guests. So I'm going to start just by introducing you a little bit to Kindbody, and then Dr. Westphal and I are going to sort of give you a little summary of the medical parts of this process. And then we'll let Whitney take it away and talk about it more from just being a patient and patient experience. So just Tracy introduced you a little bit. Kindbody is a full service women's healthcare clinic with a primary focus in fertility, and we provide the full spectrum of fertility care here in our 3 clinics. That includes everything from just assessments and understanding any individual understanding fertility to fertility preservation, helping patients to conceive in many different ways. People are having a hard time conceiving or conceiving with third-party reproduction, which is primarily what we're going to talk about today. So again, this is just sort of a list of our full spectrum of services. And I think when we think about family building for LGBT communities, or for anyone really, it's helpful to think about what are the basic building blocks that you need to create a pregnancy, and where can you get those different building blocks, right? And there are many options within each of these different components. And so on the most basic level, in order to conceive a pregnancy, we need an egg, we need sperm, and we need a house. We need a place for the pregnancy to grow, which is the uterus. And then depending on the method of conception, you may or may not need the fallopian tube. So I think it's helpful to just break it down piece by piece, and that's what I'm gonna do. And then Dr. Westphal, after I do that, is gonna sort of summarize all the various treatments that we can use to get all the parts together. So starting with the egg, if I can get my screen to move, perfect. All right, so the first step is always
to talk to a doctor, right? It's really important for us to understand who you are and what your reproductive goals are. So it's really for us to be able to explain all these options for you, we need to understand kind of where you're at and what your reproductive goals are. So that's always the first step. Talking about the eggs is sort of the first component. So if you are a female assigned at birth, you have eggs. And if you're a male assigned at birth, you won't. So we'll talk about the different sources of eggs. So for females assigned at birth, we need to assess those eggs. And there's two major components to the eggs. There's the quantity of the eggs and the quality of the eggs. And so you may or may not know this, but for us as females, all the eggs, everyone who's assigned female at birth, all the eggs that they're ever going to have are in their ovaries the day that they're born. We don't make any new eggs throughout the course of our lives. And so two things will happen over time. We lose eggs. That's a quantity phenomenon. That's egg quantity. And the quality of those eggs also decline. So in part of that initial assessment for someone who's female assigned at birth, we are trying to get a sense of the quantity of the eggs primarily, because that's something that can actually be measured. And we measure that with ultrasound. And we measure that with blood tests, the primary one being AMH, and that can give us a sense of egg quantity and often comes into play when we're trying to understand what's sort of the best path for treatment. The quality of the eggs really refers to whether or not these eggs are normal eggs. So as we get older, the percentage of eggs that are actually normal eggs that will ultimately result in a pregnancy decline. And although that's not something we can measure, it's largely an age-based phenomenon, it's something that we will include as part of the conversation. So again, female assigned at birth typically have eggs that are usable. There are certain particular circumstances where that wouldn't be the case, but often the focus is on using those eggs. And the assessment that we do is of the egg quantity, and we talk about egg quality even if it's not something we can directly measure. Now, for someone who is male assigned at birth, or there are certain individuals who are female assigned at birth that for various reasons might also consider using a donated egg. And donated eggs come from another female, someone else who has eggs, who typically, the most typically, especially when you're using an anonymous donor, is someone who's very young, someone who's often in their 20s and thus presumed to have good egg quality. There are two different kinds of donors. You can use an anonymous egg donor, so somebody that you don't know, or someone who's known to you, a friend or a family member. And again, we sort of walk you through these options, and a lot of people come in with an idea already of what they want to do. When using an anonymous donor, even within that, there's two different options. There's what we call a fresh egg donor. So that means that you typically through an agency find a donor that you would like to use. She undergoes an IVF cycle, and every egg she produces from that cycle is then donated to you. Frozen eggs are from donors who have already been stimulated, and those eggs are frozen. They're in a bank, in a frozen egg bank somewhere, and you purchase those eggs in sort of groups, 6 or 8 at a time, sort of as dictated by the agency where you're purchasing the eggs from. So that's the other source of eggs is through a donated source. And I guess I should just pause to say that as we discuss this, anytime we're talking about a donated gamete, a donated sperm, or a donated egg, or even a borrowed uterus, we refer to that as third-party reproduction. So when you hear us say that, that is sort of what we're referring to. So again, as I just introduced these two different concepts of using a frozen egg versus a frozen egg donor versus a fresh, a lot of that decision is back to that initial consultation where we need to understand what are your goals, what's your family planning look like, and so how many children do you want to have from this egg donor, and so those are genetic testing. This mentions genetic testing here. Are you trying to screen out a specific mutation that maybe your partner carries? So we get all that information to help guide you as to which is the best source of eggs for you and your family. Next is the sperm, right? So we'll need, you'll need a sperm source as well. Individuals that are male assigned at birth typically can produce their own sperm to be used to create a pregnancy. Again, there are some rare instances where that's not the case, but the vast majority of time that is true. And when you're an individual that is female assigned at birth or in a same-sex female relationship, then we are typically talking about using donated sperm. So regardless of the sperm source, we'll want to get a sense of what the quantity and quality of that sperm is, and that's typically done with a basic semen analysis where the sperm is looked at under a microscope and we assess the various parameters that are listed here. The concentration refers to the number of sperm that's in the specimen, the motility refers to what percentage of the sperm are moving, and the morphology refers to what percentage of the sperm are shaped normally. And then we can use those numbers to get a sense of whether we expect fertility or subfertility from that specimen. Back in here. Oh. This is, I think, a question that we get not uncommonly. When I was talking about eggs, we talked a little bit about the impact of aging on the quality of the eggs. And so, the question often is, well, does that same thing happen in men? Do men also see a decline in fertility as they age? And yes, they do, but it does happen a little bit differently in men than it does for women. And that's because sperm production is regenerative. So I mentioned to you that for females, all the eggs they're ever going to have are there in their ovaries the day we're born. And for men, it's actually regenerative. So there are sperm cells in the testicle that can continue to generate new sperm throughout the course of a man's life. So we do find eventually, though, those sperm cells have undergone so many divisions that they sort of get tired and will not be as good at producing new fresh sperm as they were at a younger age. So there does tend to be some impact of aging on male fertility. It just tends to happen a little bit later in a male's life than it does for females. And then there are other ways to try to overcome male factor infertility in the treatments that Dr. Westphal is going to discuss in just a second. For individuals or couples who are planning to use, this is jumping out, a donor sperm, we will help you with that process as well. Donor sperm can come, again, in two forms, either an anonymous sperm donor, just as we had talked about with the donated eggs, or from a directed sperm donor. And again, a directed sperm donor is somebody that is known to that individual or couple. Anonymous sperm typically comes from a sperm bank, and we'll let Whitney and some of our other patients talk about how they selected their sperm donors. A lot of it is personal preference, and there are a few medical considerations that need to be taken into account, and we walk you through that. It has to do with genetic testing. It has to do with checking for something called CMV. So we walk you through that as you're selecting a sperm donor, regardless if it's anonymous or directed. And then, I think Whitney, in a talk we did previously, she gave a really nice summary of some of the other things that were important for her when she was selecting a donor that are not really related to the medical side. When an individual or a couple uses a directed donor, there are some logistical things that need to be taken care of to have that donor screened, and psychological evaluation and legal contracts that we recommend being in place. But again, it's a process that is also quite doable. And the last component is the house, right? So once you have your egg and you have your sperm, there's different ways to get them together, either with inseminations or IVF, again, which Dr. Westphal is going to talk about in a second. But then no matter what, you need a place to put the pregnancy. And so in individuals who are female assigned at birth, they most often have a uterus, and when that's the case, the pregnancy can occur via an insemination or IVF, depending on how you're putting all these other components together. For people who don't, a female who doesn't want to carry a pregnancy, or a male, that will require an outside house or a uterus from another individual, and that is called a surrogate or a gestational carrier. And so And it also requires the process of IVF, which again, we're going to talk about in just a second. But once an embryo is created, that embryo can be transferred into anybody's uterus. It can be transferred into the uterus of a gestational carrier. It can be transferred into the uterus of a partner in a same-sex female relationship in a process called reciprocal IVF. So that's the last of the sort of the three components. No matter where we're putting, whichever uterus we're planning to put that embryo into, or if we're doing an insemination where we're using the eggs and the uterus of that same individual, we typically will evaluate, just as we've evaluated the sperm and evaluated the eggs, we evaluate the uterus as well. And we do that with some basic testing that we do in the clinic. There's something called a saline ultrasound, which confirms both that the shape of the uterus is normal, as well as that there's nothing else in the uterus that would preclude a pregnancy from sticking there. If we're using the fallopian tubes for inseminations, we'll often do something called an HSG, or a hysterosalpingogram, which not only checks on the uterus, but also confirms that the fallopian tubes are open. So that's the various forms of evaluating the uterus. And I think we're getting close here, so I'm going to pass it to Dr. Westphal, who's going to tell you all the different ways to put the eggs and the sperm and the house together with our certain different treatment modalities.
Thank you, Meredith. So depending on your test results and where you're getting your different building blocks and what you're using, there are a lot of different treatment options, and we really work with you to help you find the best way to build your family. If you have open fallopian tubes and you are planning to use donor sperm, then insemination is definitely an option to consider. And there are different ways of doing this. We can go with your own cycle. We can also do ovarian stimulation to help you ovulate a little bit better. Inseminations are not too complicated of a medical procedure. The insemination itself, we just take a little catheter and place it into the uterus. It's probably not much more uncomfortable than having a pap smear for people who have had a pap smear. So it's not a really big procedure to go through. And when we're deciding whether to do insemination, we take into account age and what the ovarian reserve is. So that is one option. Next.
Yes, right. Forgot that was me.
Yeah. So if insemination isn't an option, or if it isn't successful, then we may move to in vitro fertilization. And there are a number of reasons of needing to do IVF. So you could fail, less aggressive treatment if you have tubal disease, or if the sperm quality is poor. If you are older and we want you to get pregnant as quickly as possible, or if you carry some genetic disease that you want to test for, those are all reasons why we may want to do in vitro fertilization. Reciprocal IVF is where we would get eggs from one partner and put them into the other partner, so that both partners are involved. So one would be the genetic parent, and the other one would actually be the one delivering the child. Okay, next slide. So what is IVF? IVF is something that has been done since 1978. So the oldest child is going to be 42 this year. And there have been many millions of children born from IVF in the world. So it's a commonly done procedure. In the US, about 1.6% of the children that are born are from IVF. There's some countries where as much as 10% of the children are from IVF. So IVF is a process where hormones are injected for about 10 to 12 days. And in that time period, we're closely monitoring the response of the ovaries to make sure that we're getting a good number of eggs, but not too many. we want to make sure that we're doing this so that the patient is, you know, medically stable going through. Okay, next slide. And then after about 10 to 12 days of fertility medications, we see that the ovaries are ready, and you can see the ultrasound picture at the top right, where those little black circles are follicles which should contain eggs. So usually when the follicles get close to about 18 millimeters or so, we think the egg should be ready to come out. And then we do the egg retrieval. So when the ovaries are ready, we'll do a final trigger injection, and then 35 to 36 hours later, we do the egg retrieval. The retrieval takes usually about 15 to 20 minutes, and the patient is heavily sedated, usually will not even remember being in the room, but the patient is breathing on her own, so, you know, she doesn't have a breathing tube, and wakes up, you know, they're very short acting medication, so the patient wakes up very quickly afterwards. And because the procedure is just a needle going through the top of the vagina, there's nothing to see when the patient wakes up. So there may be a little bit of cramping afterwards, but as soon as you wake up, we watch you for a little while, and then you go home that same day. And the next day, you should be able to do your usual activities. So it's not a big recovery. Okay, next slide.
Sorry, skipping around. There we go.
Okay, so then when we have the eggs, the next step is to fertilize them. Conventional IVF is where, and if the sperm count is good, we put thousands of sperm with the eggs, and then one of the sperm will fertilize the egg. If the sperm count is very low, though, we need to do this procedure, which you see in the middle of the screen, a procedure called intracytoplasmic sperm injection, or ICSI. And if the sperm count is low, then we have to take an individual sperm and inject it directly into the egg. And many embryos are formed from this technique now. And then the embryos can be transferred in that cycle. So if the patient is planning to get pregnant and her hormone levels and everything look good, we can do what's called a fresh transfer. But if we are going to do genetic testing, then we need to biopsy the embryos and freeze them and get the testing results before we can transfer them. So genetic testing, there are a lot of different things that we can test on embryos. For example, if we know that a couple carries a mutation for something like cystic fibrosis, they would have a 25% chance of having a child with that disease. So we can test for specific diseases, but we can also test for chromosomal abnormalities, which is what you see on the screen here. So that is called pre-implantation genetic testing for aneuploidy. And you can see that as women get older, the chance that the embryo will have chromosomal abnormalities increases. So by the time women are in their late 30s, the majority of eggs are already chromosomally abnormal. And that is the big reason why pregnancy rates go down as women get older. So many women, as they get older, may want to test the embryos to see if they're chromosomally abnormal before transferring them. So then in terms of carrying the pregnancy, if there's a uterine problem, or there isn't, you know, someone who has a uterus in the relationship, then using a gestational carrier is an option. And most people will work with an agency to find a gestational carrier. However, sometimes people will have a family member or friend who volunteers to do it. So there are different ways of finding a gestational carrier. if someone is going to be a gestational carrier, we do want to screen them very, very carefully, because we want to make sure that we have the healthiest pregnancy possible. So a surrogate needs to have had at least one pregnancy in the past and no pregnancy complications. We do know that pregnancy complications can increase in women who have had many pregnancies. So the recommendation is no more than 5 previous deliveries. And then we want someone who is healthy with no medical issues and is not using drugs or smoking. So the screening, we will do a very careful history and physical. We do tests to make sure that their vaccinations and everything are okay, that they're not anemic, their thyroid levels are okay. And then we'll do a uterine cavity evaluation, which you see here. So there are different ways of making sure the uterine cavity is normal, but most commonly we'll do something where we will put a little bit of fluid into the uterus, and then that distends it and we can see if the cavity looks normal. So the picture that you see there is what we like to see, and that is a normal uterine cavity. And then we also have the gestational carrier undergo psychological evaluation to make sure that there aren't going to be issues down the road.
That's it. Oops. Sorry, Lynn, it
Okay.
keeps
Okay, I know. Oh.
Oh, wait.
Wait, there are a few. Okay.
Do you want to do the legal considerations?
I could just touch on this briefly.
Okay.
So depending on where you live, there are states that recognize surrogacy and then some that don't. So it's really important that if you are going to use a surrogate, what matters is where they're going to deliver. So you need to make sure that you have checked all the legal or all the laws in whatever state you're going to be in. In California, gestational surrogacy is very, very commonly done. And you need a legal contract with both the parents and the gestational carrier. And there are a lot of things that the agreement will look at. So obviously compensation, medical insurance. Even if the surrogate has medical insurance, there's some medical insurance companies that will not cover a pregnancy for a surrogate. So that is something that the lawyers will look into. You need to be very clear about what the rights of the intended parents and the gestational carrier are, and the expectations for what type of relationship you may have afterwards. And then everyone really needs to have the same goals and values for the pregnancy. So those are really important things to talk through and make sure that everyone is on the same page with what type of testing they would do in the pregnancy and how they would handle any type of complication.
We did that.
Okay. So just reviewing what the surrogacy process involves. So we make the embryos, which we've discussed, hire a trusted agency. If you're using someone that you know, we can also help you find legal counsel for that. And then there's all the psychological, medical, and legal components, the transfer, the pregnancy, and then we like to be involved. So we do confirm the pregnancy and follow for the first couple of months, and then the surrogate usually goes to see their obstetrician, but we like to stay involved and we're always available throughout the whole process.
Yeah. Thank you, Lynn. And I think it can be all sort of, a little confusing, but I think when you think about third-party reproduction, it's really helpful to think, well, what are the parts that I have and what are the parts that I need in order to create the pregnancy? And, you know, for females assigned at birth, typically there's eggs in a uterus and if there's two females in a relationship, there's two sets of eggs and two sets of uteruses. So there's multiple ways to do it, right? So you can use an insemination and somebody who's planning to use their own eggs in their own uterus. And then if you're moving to IVF and you generate an embryo with any female's eggs, then that embryo can be transferred into, we said, any uterus. And then, you know, if you're male assigned at birth, you have sperm, but you need to borrow or have donated eggs and a uterus to make it simple, as simple as possible, but that's super helpful.
Yeah. And if you have like a male couple, you could fertilize half the eggs with one partner's sperm and half with the others. So there are a lot of, you know, different options.
Yeah, absolutely. I think we'll go, Tracy, I think ready. Oops, the slides are misbehaving. I think maybe we'll what do you think, Whitney? You wanna take it away? Are you here?
She's here for sure. Or did we get her? Oh, we got to unmute her again. I can't blame you, Whitney. I would say I'm certain it's my fault. Okay,
I think it was a joint effort. We did it. Hi, Dr. Brower, by the way.
Hi, you look great.
Thank you. I'm officially in what I would like to call, people are like, how far along are you? I'm like, I'm in overall wearing length. Whatever qualifies that normal pants no longer fit, that's the trimester that I'm in.
Well, you look the same from the shoulders up.
Oh, good. They're very different from down here, but gratefully so. Yes. So everybody that's watching, Dr. Brower was responsible for facilitating this successful pregnancy. She's an amazing human doctor. She made me feel incredibly comfortable and really like she cared on a very deep level, which sometimes, you know, you feel that it's a very personal thing going through this process alone, and it's important to connect with somebody, and she was completely that for me. So thank you again, Dr. Brower, for being so amazing. Such a pleasure. But so let me just start by saying hello to everybody. And I'll just talk a little bit about my story and how I got here. And then we'll go into talking to Anthony Brown and then Adriana and Jess, and we can kind of compare stories, because everybody's story obviously is incredibly different. Everybody has different priorities, different ways they want to navigate this process, and there's no right or wrong answer to everything, and things can change. And I'll tell you, for my process personally, things definitely changed, and I had to kind of adapt as I went along, and I'm glad that I did. Initially, I'm 37, slightly rapidly approaching 38, and you know, I made the decision last year that regardless of circumstance, that this was going to be the year that I looked into family building, whatever that meant, regardless of outside circumstance. I was getting older, and I just knew that becoming a parent was something that was incredibly important to me, at least trying that. So that being said, my initial plan was actually to have a known donor and do it at home. Obviously not the old-fashioned way, but you know, my plan was to get somebody that I knew, collect their sperm, and then do ICI, which is intracervical insemination, through an at-home type kit. I will say, as things approached, that changed, and I'll get into that. But initially, my first step was going to get fertility tested, which is incredibly important. You know, growing up, you think you learn a lot about your body. You know, you live in this body your entire life. You think you know what's going on in here, but there's really a lot of information that we don't know, that the Kindbody is able to really put you up on. So I got my fertility assessment done. I got my genetic panel done, and that will assess to see if you have any type of, are predisposed to any mutations or anything like that. I believe 274 it tested me for. And that allows you to navigate your next kind of decision of where you're going to go in terms of finding your donor, because it's really important that their potential genetic mutations don't coincide with yours. And so once I got that done, I got my follicles tested, checked, and I knew I was good to go. I had a good follicle storage. Then I started making plans for, finding my donor and planning the next step. That's where things get a little tricky, I've come to find out. So, if you have a known donor, fantastic. I thought I did. And I will say, for me personally, it began to get a little too complicated for me personally, trying to navigate timing. Because, you have, even though, people get pregnant all the time and, you think that there's a bigger window, when in reality, the window is actually fairly tiny. So if you couple that with trying to schedule a friend's schedule into that very small window, things can get a little dicey. And guys, as much as I love them and they tend to be on the ball, it's like they don't always understand the brevity of window of things. And like, well, I'm out of town. Can't I just come next week? No, actually not at all. So for that reason, I started kind of reassessing. Also, we got into like a more emotional issue of things because, it is personal, and they touched on it briefly in the slideshow. But, definitely getting into the legal aspects of things. You want, for me, I was looking for somebody who was not going to be an attached parental role. And, things start coming up naturally. They had more questions about their involvement. And so for me, that was the time when I decided that my number one goal here was, conceiving. And so in order to do that, I decided to move forward with something that, to be honest, I didn't see myself doing, which was going to a sperm bank. So, in doing that, and initially, the reason why I wanted to use a known donor was because I felt like I wanted to feel their energy and I wanted to have a connection with them, because I felt like that was important. But getting into the sperm bank, utilizing the sperm bank, and I used Seattle Sperm Bank, they have audio recordings, they have a lot, just a whole wealth of information there that makes you feel really comfortable. And for me, I was able to feel very connected to the person that I ended up selecting as a donor. And that was really important to me. We shared similar value systems, similar senses of humor, and I just felt an overall connection. So ultimately, that was something that I actually was much more happy about doing than I thought I was going to be initially, and much more comfortable doing. And it really, for me, allowed a much more streamlined process that could get me to my end goal, which was clearly pregnancy. So yeah, I selected, so I went into Kindbody, and I got my whole panel checked. I got everything checked, and I ended up doing my first round. I decided to go natural. So that was with no assisted hormones to increase your follicle production or anything like that. I did, however, take a trigger shot. So basically, an additional thing that I didn't know when it came to ovulation and insemination and pregnancy was your LH surge. I didn't know about LH. What was LH? When was it surging? What does this all mean? But it is basically the specific time window that when your LH surges, that is the time that you will have the highest success rate for insemination. So I did take a trigger shot. It goes in your stomach. You put that, so basically you go in and they check your follicles, see where they're at. And then if you have a healthy amount, or they're at a healthy size, 18 centimeters, I believe, right, Dr. Brower? 18.
Yeah, that's 18 millimeters.
Centimeters, imagine, it's a giant. It's already a baby.
Like your baby right now.
My baby's already there. Yeah, so basically then at that point, you go home, wait a couple days, and then take the trigger shot. And after that, you wait 36 hours and go in and you get inseminated. It's a lot of hurry up and wait. Because then you get inseminated, and there was all this anticipation and speed and stress going in there, and then all of a sudden you're just tapping your foot for the next 12 days waiting to see if it took. For me, my first one was not successful. So for the second round, I decided to personally just jump right back into round 2 to doing it right over again. And that second time I decided to do it with assisted hormones, the Clomid. So it's just pills. It was pills for 5 days. And basically that increases your follicle production. If I'm ever wrong with my technical, Dr. Brower, you tell me.
You're doing great. You're doing great. Everything you're saying is fact. And yeah, the purpose of that was just we sort of said, hey, look, you can do this again where you just release your 1 egg every month because that's what your body does on its own. Or we said, but you're 37 and you're almost 38. And like you said, you're kind of in a rush. And so there is a medication you can take to try to get you to release more than 1 egg at a time. And that'll increase your odds of conception and also slightly increase your odds of more than 1 baby. And then you said, let's do it.
I said, let's do it. The more the merrier, potentially. But so yeah, I took these pills, I took the Clomid, and it created 3 healthy follicles, which again, like she said, it does increase your risk of twins, or multiples rather. But again, for me, ultimately my end goal was my priority, which was I wanted to be pregnant. I knew my time clock is potentially running down. So for me, it was just getting to that end goal in the healthiest and most and the quickest way possible, basically. So that second time around, I again took the trigger shot. I went in, brought my Seattle Sperm vial that gets shipped to you overnight. I brought it in. They basically thaw it out. They check and make sure there's a high amount of mobility. They test for the numbers of active sperm and make sure that it's a high enough quantity. I will say Seattle Sperm has had an incredibly high quantity, 22 million, I think mine had in that. So sounded good to me. I figured 1 out of 22 million has to take here. And then it ultimately ended up taking. So now I am 6 months pregnant. I really, in going through this process myself, they always say, your parents will always say, and I can vouch for that because my father's in here somewhere. I saw him. Your parents will always say, there's no perfect time to conceive, right? You're never as ready as you think you are. You're never ready. And boy, I didn't plan for a global pandemic to happen during my pregnancy at all. I thought I was completely as ready as one could be prior to that, even though I was, single and this and that, and that wasn't my ideal, landscape. It wasn't something that I had necessarily planned out, but in kind of going into this new normal, this modern time and things that we're adjusting to, I have to say, if you're questioning, if you're second guessing, or if you're waiting for the right time, I think the best thing to do is just collect as much information as you can in order to make the best educated moves. Because whether it be freezing your eggs or just going for it, I think that there's incredible power. It's incredibly empowering, learning as much as you can. There was a lot, like I said, that I didn't know, that I thought that I knew, that I just didn't know, that really allowed me to comfortably enter into this next phase of my life. So even though we are in this new, very uncertain times and things like that, I feel incredibly, empowered going into this whole process and this next stage of my life. And I'm very thankful to Kindbody and assisting in that and things like that. And I really am feeling very grateful that I'm able to facilitate any conversation or information relay between, members of the LGBTQ plus community and people like Kindbody or Seattle Sperm Bank or surrogacy programs or anything like that, to really empower those that are looking to join this journey as well. So that is my story personally. I would love to, like I said, everybody's journey is kind of different. I know that Adriana and Jess, you guys are here, right? I see you there. Hi, congratulations.
Thank you.
You guys are you guys are 4 months, right?
4 months this week.
Wow. Are you currently in the, have you entered into the overall trimester?
I was in overalls, I think, before I was even pregnant, but I've officially entered into wearing some maternity clothes, which very comfortable.
Yeah.
They are. I know. When I clicked a purchase button on my first maternity pants, it was like the click heard around the world. That's what I felt. Well, but congratulations. So would you guys like to share a little bit of your journey and maybe how it differed from mine, or what you guys, the steps you guys took to get to where you're at now?
Yeah. We actually have a lot of overlapping elements in our stories. But we sort of started looking into family building and kind of the path we would take right when we got engaged. So we knew we wanted to kind of start trying right after we got married, which we ended up trying a little bit before our wedding. And so we started right around the time we got engaged, and Jess and I sort of went through the process together, which was cool. We knew that we would each want to carry a pregnancy at some point. So we both, went to Kindbody, found them. We're so lucky that we did. Immediately felt really comfortable with everybody in the office, and we went to do our fertility assessments. And I knew that I had some underlying issues just from some health things that happened in the past. So Kindbody sort of directed all of the testing and kind of walked us through the whole process. And so I've had some uterine polyps and a blocked fallopian tube. So I knew the road wouldn't be super easy. So we kind of wanted to get a head start on everything. So went through all the testing. I actually had to have polyps removed with Dr. Cezanne in New York. This was all before the wedding. And then we decided to go through IUI, and that I would go first just because, I had all those issues. So I figured just to kind of have time on my side a little bit. So the first IUI we did was unmedicated, similar to you, and it didn't take. So then we decided to sort of move on and do the next try with medication. So it ended up taking 4 tries for us, 1 unmedicated, 3 medicated, and actually did 3 different medications for those 3 last insemination tries, and the 4th one took, really luckily. And so the insemination was in March, and we actually were the last insemination before Kindbody shut down in New York. Wow. Because of COVID. So it was pretty lucky. It was very lucky. Yeah. And we, we weren't sure. Dr. Brown sort of said, do you want to go through with it? Do you not? And I said, well, I've been injecting myself for 10 days, so let's just give it a try and see if it works. So we ironically have a Corona baby.
Can I ask, so the final hormone treatment that you took, that was injectable?
Yeah, so we ended up doing Follistim, which is an injectable, and that seemed to do the trick. Just 1 baby. So
yeah. How long is that hormone treatment, and what is the cycle of that?
So I did it for I think I did it for the full 10 days that you can inject, and then I think it was 2 or 3 days in between, and then the trigger shot, and then 2 days later the insemination. It was 2 days after my birthday.
Okay. Yeah. Can I ask Dr. Brower, the Clomid versus what was the one that you just said?
Follistim.
The Clomid versus the Follistim. How is it usually that you would attempt with the Clomid first and do a couple tries and then move on to the one that was successful for them?
Yeah, it depends. So the overall goal of those medicated cycles is the same, is to try to get more than 1 egg to be released. So as we mentioned, right, in these natural cycles, what our bodies do on their own is typically to just release 1 egg. And there are many, many, many different ways and sort of recipes that you can use to try to trick the ovary into making 2 or 3. You don't want 10 eggs, right? Because then your risk of multiples is too high. So sometimes you can do it with the medications, the oral medications, which are Clomid and Letrozole, or which I imagine you guys, Adriana, may have done first. And then sort of a more aggressive way to do it is to use like something called follistim or gonal. It's actually an injectable form of follicle stimulating hormone. And so the purpose is the same. It's just a little bit more, it's just a like slightly more aggressive way to do it. And you can use them in combination. You can use combination protocols where you take some orals and then some injectables, or you can do a protocol where you're just taking those injectables. And typically you start them, as you probably recall, around second or third day of your period if you're just doing injectables, up until the time when you take the trigger shot. But then the process is the same, where we check on the follicles, how many are there, how big are they, to try to say, okay, if you're doing a trigger shot, which we often do to try to do a very well-timed insemination, all right, take your trigger shot on this day at this time. So as you mentioned, Whitney, 36 hours later, you can do that insemination.
Okay, so Adriana and Jess, when you started the process, you said that you guys started it prior to the wedding, and then it took you 4 times. Now, did you ever take a month off, or did you just keep going back to back?
We did. We actually I think the whole process was 6 months. Mm-hmm. So we did 4 inseminations in 6 months. So 2 months we took off. And I don't really remember why. I think
one like lined up right with our wedding, actually.
Oh,
so
yeah.
We couldn't make the appointment.
Couldn't make it.
We were in Pennsylvania and had to get to New York. So I think that was one, but I don't remember the other.
Okay. And then just in talking about your, I know for me, like I said, I ended up going with a sperm bank for the donor. What was your donor searching process like, and how did you come to that decision?
Yeah. I think this was probably the trickiest process for us. It's a big decision to kind of include. It's a big piece of your family, and you never get to meet this person. So we actually went with Seattle Sperm Bank as well. Yeah. And we went back and forth. We had kind of a short list of donors that we both liked. And we kind of went back and forth on characteristics and, we tried to choose somebody since our plan is for both of us to use the same sperm donor. So eventually for Jess. So we tried to pick somebody that kind of looked in between us, but that wasn't the most important, really, the looks. We really relied heavily on the audio clips and the descriptions and the staff descriptions of the donor. The one that we chose just had, loved his family, had a really good relationship with his family, which was important to us. He was outgoing and, smart, but athletic. So, we just wanted somebody well-rounded, give our kid the best chance they could have. And we kind of ended up agreeing and settling on one. And so we bought up all the vials he had left.
Yeah, that's what I was going to ask. So you guys ended up buying them all and storing them.
We did.
For future.
When I eventually step up to bat, but we'll get there eventually.
Very, very cool. Yeah, that's something that people have asked me a lot. How many vials is best to purchase? How are you going into this? Like, should we get several, store them? How many is good to just do it right off the bat? I personally got them one at a time and just went that way. But if you're planning multiples, for me, I'm envisioning this being my only one that I personally give birth to. My only child that I give birth to. But yeah, so something to keep in mind and think about for those of you watching is if, like how they are in this situation, if you have another partner that wants to carry, or if you are planning on carrying another in the future, definitely take that into consideration and plan ahead. Because I actually had a friend of mine that, went back after to purchase more, and they were sold out. And sometimes they can contact them. And I believe we'll speak later with Seattle Sperm Bank. I think that they're in here. But, sometimes they can contact them and things like that. But sometimes when it's gone, if you will. But that is so amazing. Congratulations, you all. That's so good. How far do you see yourself waiting in between your next?
That's a good question. I think we're being very idealistic and saying, oh, maybe we want them kind of close together. I'm close in age with sister born after me, and I love that relationship. However, I think we'll see what the challenge is once we have the baby here. Yeah.
Right. So that's from the time that you guys started this process to the time of conception. What was the whole timeline looking like?
Exactly a year.
Wow. Okay.
We started kind of a year ahead,
Yeah.
and we took our time. We didn't feel pressure, and we kind of set ourselves up to think that it might take longer than we originally had hoped. So we actually feel pretty lucky that it worked, after 4 IUIs, and that we kind of didn't have to venture into the costs associated with IVF and also all the extra medical procedures. So we got pretty lucky.
Yeah, definitely.
Right. I have somebody asking here, how did you all decide who would get pregnant first?
We decided, just because I had had the fallopian tube issue, that it would be smarter just to have a year or two on my side to start trying. But it didn't really matter, honestly.
Yeah.
I think if it wasn't for that, maybe we would have flipped a coin or something.
Yeah. So I also had all the testing done up front at Kindbody. So I kind of knew that things looked pretty good for me. So I think that helped us to kind of prioritize and, go with Adriana carrying first.
All right.
So
Great follicles.
Great follicles.
Great follicles. Fantastic. Do you mind if I ask your ages?
We're both 30.
Yeah.
So the insemination that worked happened 2 days after my 30th birthday.
Oh, very nice. That's so good. I'm so happy for you guys.
Thank you. We're excited.
Giving birth at similar times, kind of.
Yeah.
But I'll let you know how it is.
Yeah, keep us posted.
Yeah. In advance. When do you guys do?
December 7th.
Very nice. I'm due October 16th. So
It's
a good birthday.
Yeah.
yeah, exactly. Well, thank you guys. You guys have been incredibly helpful in this, and I love hearing your story. It's so interesting to me just to hear everybody's, individual perspective and their own journey on things, because everyone's is so different, and the reason why people choose things are so personal, but so unique to everybody's story. So I'm really happy for you all, and I can't wait to see what happens in December.
Thank you. And congrats to you too.
Yeah.
Thank you. And I know we have Anthony Brown with us. Anthony, are you here?
I'm here.
Hi, how are you?
It looks like my name is Lauren, but I'm actually Anthony. I'm sorry.
I saw that. You look much more like an Anthony.
Yeah, thank you.
Wearing,
so true.
yeah, you're wearing well. So I just want for everybody watching, obviously, when we get into things with family building, family planning, I feel like a lot of times the conversation is centered around women, whether it be infertility, which to me is, and I've heard Dr. Brower speak on this in the past. Infertility is a big component. It's not just women. I think we as women tend to kind of personalize that and internalize that a lot. And there's this whole other factor, whether or not you have the man involved, whether or not you don't, there is this whole other factor. So being able to hear men's side of things, because another thing, even though we have the whole infertility debacle that we deal with kind of facing, we also have a uterus. So it's easier for us, I think, to, explore different options in order to fill that uterus, for lack of better terms. And, for gay men, you have this whole different component that you have to acquire. And it's a much, larger commitment. Am I right, Anthony? It seems like
it's fascinating. There are no accidental surrogacies.
There are none.
I mean, it's the same also for women anyone in the LGBTQ plus community. We are so carefully planning this process out that it's so intentional, and there's so many different steps involved.
Right.
But you're absolutely right. I mean, it's a big process, and an interesting one too.
Yeah, it really is. I mean, like you said, exactly. It's so intentional every step. And that's the beauty in this. There's a very beautiful, energy behind all of this LGBTQ family planning and family building, because there's such an intentionality, and there's such a love behind it. I know for you, you used a surrogacy. I'll let you tell your story. You have an 8-year-old son. Is he 8 now?
No, he's 10, and he just graduated from elementary school yesterday.
Wow, congratulations. Was it a virtual?
It was virtual. It was virtual, but it was real tears. So,
yes. Yes.
But it was wonderful. But I basically, my husband and I, we've been together for 30 years. We never thought, when I came out, I never thought I would ever get married, have a family. It just kind of evolved. But it evolved through the help of very close friends of ours, a lesbian couple who I was a donor dad for. And my oldest daughter through that relationship is 15. And then they had a second child who was 9. We were very much, from a legal perspective, I'm an assisted reproductive attorney here in New York. So I knew the documentation we needed to do to secure their relationship. I think they had the same intention you did initially, to have a known donor. They wanted someone for their children to connect with, but they wanted to be secure that it was their family. And that was exactly my husband's and my intention also. And I remember when you were saying about men not understanding the brief moment of availability, because we tried to do what we termed fresh direct for about 4 or 5 months. And I would get a call, I'd be, at a show or, doing a talk somewhere, and you gotta come over. And we ended up going into IUI, and that's how the oldest daughter was born. But I think my husband and I learned from that experience. They wanted us to have a relationship with her and her with us. And through that relationship, we realized that we really wanted to be parents, that it was a different and wonderful relationship with her, but we weren't her parents. So we started looking around, and one of the things that we really wanted was to have a relationship. Because of my being a known donor, we wanted to have a relationship with our egg donor. And so we wanted to find an agency that would foster that and support that. And Circle Surrogacy is our agency. And I've been lucky enough for the last about a year to be an outreach associate for them. So when couples are thinking about surrogacy, I will kind of walk them through the process. And one of the things that we say about the agency is that we are a full service and relationship-based agency. So we have an egg donation portion of our agency, and we have many egg donors who are open to being known egg donors. So for us, our criteria really, that was one of our big criteria. We knew that because I was a donor dad, that my husband was going to be the sperm source. So I got to kind of have a little bit more control in picking our egg donor. So, but first and foremost, we wanted someone who was open to having a relationship with us. Which was a little bit difficult to find. They have a pretty large egg donation bank. And once we were able to narrow it down, we said to ourselves that we really wanted to meet these people in person, both our surrogate, our gestational carrier, and our egg donor. We wanted to meet in person before we made any arrangements, before we signed any papers. And when we met Holly, our egg donor, we knew immediately. She's just an incredible person. And she brought her son, and she brought a bunch of family photo albums to our hotel room. My husband and her son bounced on the beds, and she showed me her family photo albums. And like the second she left, we both looked at each other and went, "We got it." So we knew immediately. And also with Shannon, our carrier, we went down and we met Shannon and her husband and her family, and we knew immediately, because we wanted it to be a really collaborative process. And Circle fosters that process, which was really—
So Circle will foster both finding you the donor as well as finding you the surrogate and facilitating that whole—
Yes. Circle has a separate egg donation agency as well as the surrogacy agency. They do all of the screening that is involved with the egg donors, and particularly all of the screening that is involved with the surrogates. And I believe Dr. Westphal was talking about the screening process that surrogates go through. And it's really quite a stringent process. I think Circle is I think the largest agency now. we get about 2,000 applicants to be surrogates per month. And from that, we end up accepting into the program about 25 a month. So it's a
and of that number, how many would you say are willing to be known?
Oh, well, from the surrogacy point of view.
Surrogacy, but from the egg donor as well.
From the egg donation point of view, it's probably 60-40 willing to be known. With surrogacy, obviously, it's a known experience. It's a collaborative experience. And it really, the screening process, the surrogates who come into the program are supported completely along the way. When I sign up with Circle as an intended parent, you have like this team that's associated with you. You have your own lawyer and accountant. You have your own social worker, which was really helpful. And then you have 2 sort of journey coordinators. But the surrogates also have their own social workers, and they have a big support community amongst themselves to help them go through the process. So not only are they medically screened, but they're psychologically screened, just to make it to that eligibility pool that they're presented with intended parent profiles and vice versa.
Right. And let me ask, in terms of, I know for women it can be, or for couples trying to get, go through the fertility process, it can be very costly. But I know for men, it is a much more inflated cost, it tends to be, right, on that.
Yeah, the costs can be very prohibitive. One of the things I was very lucky to do, I was the founding board chairman of an organization called Men Having Babies, which educates gay men about family building through surrogacy, and then introduces them to members of the surrogacy community. And one of the things that we did, we were a part of the Gay and Lesbian Center here in New York City, but we branched off because we had to create a foundation. We wanted to be able to create the ability to help people who couldn't afford the journey on their own. So there's a program called the Gay Parenting Assistance Program. If anyone is interested in it, if you go to menhavingbabies.org/assistance, you can see the application, and basically agencies that are involved with Men Having Babies donate services. Circle is one of the big contributors also. And then if you are selected, you can either get, say, a 20% discount on the agency fee, or if you make it to the second stage of the assistance, then it's actually donated services. So you still have to financially come up with a component of it, but not the entire amount.
Wow.
Which is pretty costly, because you're not only talking about the costs with the agency, but you're also talking about your costs with the clinic. So you really are looking at two separate categories. And with Circle, our costs are around $145,000. We have a guarantee program that's $155,000, but then there's another $30,000 to $50,000 you're paying your clinic on top of that. So it is definitely something that, if you're thinking about it, it's a budgeting issue as well as an emotional issue, and and how you see your family in the future.
Right.
It's definitely something you gotta consider.
Right, but the reward is so amazing.
Oh my gosh, it's incredible! It's absolutely amazing, and my husband and I were fortunate enough to go through the process, and I look back on it now, and all the little bumps and all the little things that can happen, that I think anyone who goes through pregnancy knows.
Right.
They kind of fade into the background when you have your family and it's there, and
right.
I wouldn't have traded the experience for the world.
I'm sure. That's amazing. Congratulations. Oh, just one final question. I know we have to go to Donor Concierge. In terms of your surrogacy, how directly involved are you? How often do you see her during the process? Are you in constant communication? What's your relationship building like in that?
That's a great question, because one of the things at Circle is that we actually build into the agreements with the carriers is a communication plan. So during the pregnancy, I was probably a little more involved than Shannon may have wanted me to be, because I was learning all of this stuff, new. I was so excited. She'd already had 2 children. She knew all the things that I was texting her about so eagerly. But Yes, we would speak with her probably once a week during the pregnancy. We have kept up with her now. We've seen her since Nicholas is 10. We've seen her about 5 or 6 times, but we talk on the phone. One interesting fact about exactly what you're asking, there was a study done specifically about gay men and the relationships with their surrogates by the Center for Family Research at the University of Cambridge in England. And my husband and I got to be a part of this longitudinal study, and they interviewed us, they interviewed our son Nicholas, and they interviewed Shannon, our carrier. And they found that basically after the child is born, there's sort of a flurry of communication with the surrogate. And then it gradually, as the child gets older, it kind of wanes a little bit. And then it becomes maybe a couple of calls a year, or a Christmas card or Mother's Day card. But the key finding of the study was that evolution, natural evolution of the relationship, both the parents, the surrogate, and the children were all satisfied with, that they understood that that was sort of a natural progression.
That's beautiful. That's absolutely beautiful.
Yeah. And we also are still in touch. We saw Holly, our egg donor, last summer. She's in the military on a station on an aircraft carrier. So we don't get to see her very often, but she's finally now on the East Coast for a while, and we are able to see her.
That's amazing. That's amazing. Yeah. Well, congratulations, and thank you so much for sharing your story.
It's my pleasure.
Congratulations again. I know we have to go to Donor Concierge, right, Tracy? Are you over there?
Sorry, I muted myself because yes. There's too many dogs at my house. Who let the dogs out would happen right in the midst. Anthony, thank you so much for sharing. And Meredith, will you pull up a slide? I want to introduce Michelle Laurie Smith from Donor Concierge. And just to also bring up Anthony, I'm going to wrangle Anthony for another event because I really want to go a deeper dive and talk about all the elements, because he shared some amazing slides, but unfortunately, as we're already 90 minutes, and for our East Coasters, you guys are like, and especially our poor pregnant Adriana's like, I need to go Mimi's. It's time to go to sleep. I know she's going to turn into a pumpkin over there in Cinderella Town, but I know that our time is short. But Anthony, I thank you so much, and I can't wait for us to talk more, because again, it's a true pleasure to be able to share this and to share how important family building is to all of us. And I thank you for joining us tonight.
You're very welcome. Thank you so much for having me.
Of course. Okay, Michelle, are you here? There
I'm still here.
Yeah.
I have to say, I've been tearing up a little bit sometimes hearing some of these stories. Yeah. This is what happens in our office, is we start tearing up every day. Thanks. Hi, everybody. So I'm Michelle. I'm with Donor Concierge. We're not an agency. I like to say we're a wedding planner. We're a wedding planner for third-party fertility, and I think Dr. Westphal and Dr. Brower referred to third-party, meaning when you're going through a process like this, there are so many different moving parts, and there are things that you think you know, but you don't, and Whitney said this too. You go into this thinking it's going to be really easy. It's going to be finding a donor. It's like going to Amazon and just pick one. And it's not like that at all. There are always going to be stumbling blocks. So we started doing this work in 2006 and founded by a woman named Gail Sexton Anderson, who I know has worked with Dr. Westphal for many years, probably since before 2006. And really what we are is we're an independent resource for everybody who wants to build a family. And we call you intended parents. I like to say hopeful parents too. And we help people navigate through all the different agencies and figure out how to do this. So most of the work may be finding an egg donor. You might be trying to find a surrogate, a gestational surrogate. You may be trying to find both. You may be trying to find a sperm donor. So we step in and help you present you with candidates who fit your family. And I know there was a few questions about how did you choose the donor? What things did you look for? And those are the sorts of things that we go through with our clients about what's important to them. So for some people, it's ethnicity. For other people, it's height. I had a client, for instance, and she was a very successful attorney in her mid-40s, and she had tried unsuccessfully with IVF. And she also happened to be 6'3" and a volleyball player. So for her, that height and that athleticism was really important. So what we did was we have access to all the egg donor agencies in the US, and we basically go through all the profiles that are out there and then we curate a list of candidates for those clients. And we can do that with sperm donors as well. So if you don't want to we do work with Seattle Sperm Bank, and they're awesome. So we work with people who want to basically do their due diligence of finding the candidates that are right for them. And that also extends to surrogacy as well, which again, as people have talked about, is a very particular match. So there's a lot of things that go into it, such as location of the surrogate, what type of relationship do you want? Are you able to be there at every medical appointment? Are you both on the same terms, same wavelength when it comes to things like termination? You know, what are all the things that we kind of anticipate, all the things that could go wrong. So we're here to help you find. You may need an attorney. We want to make sure you've got mental health support. So we have a network of mental health therapists who can support you through this journey. And again, you know, really helping you do this fairly quickly. So we have a lot of people who come to us after they've tried to do this on their own, and they found it very overwhelming. They also can find it quite emotionally overwhelming too. I think there's around 120 different egg donor agencies and around 50 to 100 surrogacy agencies, probably more actually. We've really vetted all the agencies we work with so that we're only working with those that we know and love and we trust. We want to make sure it's a smooth experience for everybody. So by doing so, we can help you find the candidates that you need very quickly. So that's it. There's a lot there.
Thank you so much, Michelle. Meredith, will you switch to the next slide? Because I know for the sake of time, I really want to share a few things about pricing and discounts. And then I'm going to throw it back to Whitney because she, on her Instagram-orama, asked a bunch of questions, asked everybody to give her questions. And so she has some, and she has some for Seattle Sperm Bank as well. And we're going to bring Elise on in a moment. But insurance accepted. So that's really important. We really work with all major carriers. Something that I answered in chat, it's really important to call your carrier. And even though we say Aetna and all these wonderful carriers, you need to call them and to make sure that you have fertility benefits. It's a whole different situation. You may have medical benefits, but not have fertility benefits. And then if you have fertility benefits, you have to make really sure and find out specifically what that looks like. Because unfortunately, there are some carriers that not intentionally, but exclude LGBTQ couples, the way the things are written, the way the language is. So to that end, I have to say that you can be your best advocate is go to your employer, because we also provide benefit and we really fight the good fight every day. We're contacting and working with employers to create and let them know that we are inclusive, our prices are lower, and then we can work, because we accept insurances, we can work as a wraparound and be that fertility benefit. So go to your HR person, have them reach out to us. We have a whole page on our site because we really want to, honestly, our entire mission is to provide inclusive, accessible care. And how we do it is how we're learning in society right now is we need to raise our voices. And that's what we really, all of us here at Kindbody every day really try to do, is really to provide that the best way that we can. And then Pride 2020 is going to be the discounts. And on the next slide, we'll explain a little bit more about that. So a few things here's how you can book your appointment. It's as simple. And the wonderful thing, we are the only fertility center where you can book online. So if you go to kindbody.com/book, you can go in there and we are offering discounts on IUIs. That should have said 1,000. It's for attendees. So instead of it being $1,200, we're giving a $200 discount. We're offering $1,000 off cycles and also off our IVF cycles. And then we can go, and that was for till the end of June. And it doesn't mean that you have to have your services or your appointment have to be, you can book your appointment for July or August. It's just so that you can get that, as long as you're in there, and they're not going to charge you in the moment. They'll charge you at the time of your appointment. So you can just go in there and book your appointment. And as long as you book before July 1st, then you get the opportunity to these awesome discounts. And you just put Pride 2020 inside for the code. Lena, you can absolutely add your code in there. Absolutely. Both of you, absolutely add your code. Okay, sorry. Okay. Yeah, sorry, Meredith, I'm like back and forth. Okay, so we're gonna talk about, Seattle Sperm Bank, who Whitney worked with, and our lovely friends. You guys are like, maybe your babies are cousins, jokingly, Whitney. And yeah, but you came from the same company, the same CO. Yeah, exactly. So Seattle Sperm Bank is offering a 3-month all-access pass membership. So all you have to do is email them at cs@seattlespermbank.com, put in the subject line Kindbody, and they're going to offer you the 3-month pass and a complimentary consultation. And so Whitney, I'm going to give it back to you. I know you had some questions, and then we have to wrap up, but I really want to thank everybody for attending. I know it's a lot of information. It's like a sex ed class, but then we get to meet really fun, amazing people from around the world. So thank you again for everybody for joining us.
Yes, thank you, everybody. Do we have Elise?
That's our Elise. Okay.
From Seattle.
There she is. Hi, Elise.
Hi, everyone.
Hello. Wait, is it? Oh, hi. Hello. Hi. I haven't seen you in so long.
I know.
How are you doing? So yeah, I just wanted to chat with you because a lot of my questions that were coming through my Instagram were directed towards your services at Seattle Sperm Bank. I just want to touch, there was something that I didn't mention during my story. I just want to touch on first, and it kind of leads into a question that I have, which was, for me, it was important for it to be an open donor. Some people have choose anonymous donors. Some people choose open donor. Open donor basically means that that the donor is willing to be contacted when they are 18. It also opens you up to a sibling pool. Is that the best term to use and do you guys call it a sibling pool, or or did I make that term up?
Well, we have SSB Connect, and it's sort of a platform where you can connect with other siblings, and I've heard siblings too.
So I did make up the term sibling pool. I'm going to coin it. I'm coining sibling pool now. I feel like a lot of siblings are just going to be swimming around the same thing. But I think, in talking with everybody last time when we did this, something that I thought was really amazing that you guys do, what you were just saying, is they facilitate potential conversation between other offspring that were created by the donor. The donor is able to contribute to 25 families. And that, for me, like I said, initially I wanted to use a known donor for the personalization of it, and just feeling like there was a sense of, I don't know, more community. But knowing that this was something that was so accessible at Seattle Sperm Bank, really, it really was that much more of a incentive, because, being members of the LGBTQ community, we are, the ones that really created a chosen family, the concept of chosen family, and creating your own kind of unconventional family setting. And to know that there could be, communication facilitated between other biological offspring was something that really interested me personally. It might not for other people, but for me, that was something that was definitely of interest. So, but I want to shoot it back to you, Elise. So people were asking about the screening of the donors and how in depth you go, how accurate is it? How do you kind of vet these people?
That's a great question. So when a potential donor first comes in, we'll do two things. We'll do a semen analysis and get that started, but we also interview this person and get to know their family history and start to better understand it. And it's kind of an evolving process. So, having them understand what open ID means and better understanding their family history, while also looking at the required FDA testing, and then looking at what kind of samples they're able to give, and then them understanding the commitment. You know, a lot of our donors stay in the program for a year or more. And so just understanding what that means. So it's a lot of steps. And for the most part, people don't get accepted into our program getting through all of those different steps. So by the time we get our pool of donors.
I remember you told me, I think it was like out of X amount of guys that come in, how many get accepted?
Right. So I want to say it's 9 guys get accepted for every 1,000 applicants.
Wow. So it's the cream of the crop, if you will.
Yeah.
That was my bad sperm bank joke for the day. I mean, it's a very, you can tell that the quality of person, you guys doing a fantastic job of really covering all bases and making you feel like you really get a very holistic view of them. And you were saying, how long is the commitment that they have to make?
So the minimum is 6 months, but for the most part, you know, by the time someone goes through that whole process, they're in there for a year or more.
Okay, fantastic. And then a lot of people were asking about purchasing vials. How many is the average that one should purchase if they're just starting out on this process? You know, I know a lot of people are concerned with buying too many, but then a lot have a fear of buying too little and then kind of being left out to dry.
Right. So that, I think that's going to be a very personal choice. So it depends if you're struggling with fertility and you know you're kind of anticipating this might take a couple of rounds. But you also want to think about, do you want siblings in the future? And our donors tend to go quick. So if you find someone you're in love with, it's better to have more than less. And we have a buyback program. So if we haven't shipped a vial out and it's still in our facility, we will purchase that back from you if it's unused.
Okay. And in terms of storage, is there any time length on any time cap on how long you are willing to store the sperm?
No. So right now we, with everything going on, we know people have had trouble scheduling with COVID and, you know, feeling comfortable in continuing your cycles. So we actually have free 6 months shipping when you purchase 2 vials or more. So that's a great option. And then at the end of that, you can also choose to extend your storage. And then we have special storage if you happen to have, like in your case, one and done. If you happen to have other vials stored, we offer discounted storage prices for siblings.
Okay. And then in terms of, a lot of people have asked me in terms of contacting them, because you are an open donor, you solely work with people that are willing to have open ID donorship, right?
Right. Everyone's an open ID. And then we facilitate that contact once the offspring turns 18.
Okay, fantastic. Thank you so much. I really appreciate it.
Of course.
I know we're on a little time constraint, so I want to shoot back over for a couple questions to Dr. Brower, if you don't mind, before we wrap up. But it was so good seeing you again.
Good seeing you too.
Thank you for virtual hugs, and thank you for your assistance.
Of course. Welcome to the family.
Thank you. Okay, Dr. Brower, we have a couple questions I just want to shoot over to you before we get out of here that have come through either on my Instagram or that I saw that were coming through on the chat. One is with PCOS, that's polycystic ovarian syndrome, correct?
Yep.
Does that affect, do people tend to run out of eggs? They asked specifically, do people run out of eggs faster with this, with PCOS, or does it affect fertility more? How do you guys deal with that?
So PCOS in its most classic form, women with PCOS, their ovaries are making too much or an excess amount of testosterone or androgen typically, which can be disruptive to their cycles. So to answer first the question about fertility, the main thing that we think of that's negative for fertility in women with PCOS is that they're not ovulating. So they're not getting regular periods, they're not ovulating, so they're really not getting chances to get an egg and a sperm together without some sort of intervention. So that can impact fertility. Women with PCOS also are at a higher risk for obesity. So something like, they're more inclined, and obesity is a negative factor for a negative factor for fertility. So those two things I think are the main things that contribute to fertility. But otherwise, in lean PCOS, once you get them to ovulate, typically their fertility is fine. They actually tend to have more eggs. So if you remember when we looked at your ovaries, you see all those little follicles. Women with PCOS tend to have more and run out later as a result instead of sooner.
Okay. And then another question was, for our IVF, is it possible to take a partner's egg as well as your own egg and do some type of dual insemination?
Yeah, so each partner has to do their own IVF cycle, their own stimulation, their own extraction, decide on a sperm source, so either the same sperm source or different sperm sources, and then there'll be 2 sets of embryos, one from each partner's eggs. Now, as far as where to put those eggs, we do typically recommend putting in 1 embryo at a time, right? So we talk about multiples and twins, and although it happens sometimes, pregnancy risk is lowest when there's just one at a time. Twin pregnancies are at a high risk. So in theory, yes, you could take an embryo from each partner's eggs and put them into 1 uterus at the same time, and theoretically have twins that are from each partner. But we do typically, you would have to have a conversation with your doctor about kind of what that risk is, and being willing to accept that, because we are very high percentage of the time transferring 1 embryo at a time.
Right. Okay. Sounds good. And then just 2 questions. I know we've been in here for a while, but the final 2 is overall the average rate. I've had a lot of people ask this question. Yeah. The average success rate of insemination. What are we talking? I know it's probably tricky because it probably has a lot of variables.
Yeah, I mean, understanding this, if a female comes in and she's doing inseminations, her chance of conceiving in any given cycle is largely based on her age, right? We don't presume any for infertility. There might be someone we don't know, but we don't presume any infertility because we've not really been trying, typically the old-fashioned way. And so normal cycle, what we call fecundity. So if you look at young women, so less than 35, and you look at their chances of getting pregnant in any given month, it's about 20% per month. And that's normal. That is normal fertility, which is funny. I think people are often surprised by that number. Like, what? Like, my chances only, if you sent a heterosexual couple that are 35 years old and told them to have sex when they're ovulating, their chances also are about 20% per month. So human reproduction is designed to be slightly inefficient in that way. And so that's typically the number we would say for inseminations as well. In women who are older, late 30s, early 40s, that number is probably smaller.
Right. Okay. Right. It goes down over 35.
Right. Because as the quality of the eggs decline, you're releasing a normal egg less frequently. And typically in the months that an abnormal egg is released, either a pregnancy won't occur or potentially a miscarriage can occur. So, so the odds are still good, but it would probably be lower than that 20%.
And in terms of people getting into this process and starting, would you recommend, and if so, how would you best recommend starting to track your ovulation? Should they start on their own, and how far in advance?
It's very, very helpful to at least know how frequently somebody's getting a period. So you don't necessarily need to be using ovulation predictor kits at home, but if you come in and you've already been using an app to track your cycles, it's very helpful for us to understand potentially when you're ovulating, because we can take that information and extract when we can take it and say, okay, if your cycles are this many days, you're ovulating around here. So if you're just knowing what's going on with your cycles, that is very, very helpful.
Okay, perfect. Well, thank you.
Thank you.
That will do it for that. And thank you for everybody who has been involved in this, and everybody who's contributed, everybody who's tuned in. I hope everybody has taken away a lot of information from this. And feel free to message me privately if you have any more questions. Thank you, Tracy. Thank you, Dr. Brown. Thank you, everybody else.
Thank you, Dr. Brower, Dr. Westphal, and a special thank you to my East Coast participants, especially Anthony and Jess and Adriana. I'm like, she's got a tiny baby that needs to go 9-9 in her tummy right now. And I want to thank Elise and Michelle, and honestly, every single person that attended, because in earnest, the information, like knowledge is power, and everything that we have here, like let's share it out and let them know that we are a big family, and this is the way that we can show and share that family building is an inclusive opportunity, and everybody deserves the opportunity to have the family of their dreams. So thank you, everybody. Have a wonderful, wonderful night. And we look forward to doing more events. You can always message us too at navigator@kindbody.com. We will send an email. I know Donor Concierge has some treats to give, and we have a lot of wonderful things to share. So we'll send anybody who RSVP'd, we will reach out to you. If by chance you don't receive that email in the next day or so, email navigator@kindbody, and we'll make sure that you have the information that you need. So thank you again, everybody. Have a wonderful evening. And yes, take care, and we'll talk to you soon and see you soon.
Yes, bye. Thank you, everyone.
Bye.